Unfold your beauty at the private practice of Dr. Beth Collins. I'm Tulin, the MyTV9 star, and I believe everyone should exude self-confidence. Dr. Beth Collins, double board certified plastic and reconstructive surgeon, has the same beliefs. She specializes in body contouring and facial rejuvenation, also offering non-surgical procedures such as injectables, skincare treatments, and chemical peels. Come meet with Dr. Collins in this comfortable atmosphere and leave feeling forever fabulous wherever you. Beth Collins, MD, Boston Post Road in Guilford.
So I want to talk about breast augmentation today. So the biggest decision is obviously that you're going to actually have a breast augmentation. And then once you've made that decision, you have what I think of as 4 more important decisions to make, and I'm going to help you make them. And I give this talk to everybody that comes into me as a patient for breast augmentation. So essentially, this is what you get if you'd come in for a breast augmentation consult, short of the examination and me telling you what part you fit into. But here are the 4 things that you have to think about and what we'll discuss throughout this this post. The first one is whether you're going to have a silicone or saline implant. The second thing is where we're going to put that implant. Either we're going to go above the pectoralis muscle or below the pectoralis muscle. The third thing is where we're going to put that incision. There are 4 possible places to put them, but I have a pretty big bias for one particular one. We'll talk about that. And then the 4th decision is going to be sizing of it, and I'll talk a little bit about that. That's where we do the exam on the actual patient and pick a size that fits. You have 4 places you could put incisions. I'll say right off the bat, one of them is really dumb, and nobody should ever do it that way, and it's through the belly button. There's a procedure called the tuba, or the transumbilical breast augmentation. It's really dumb. First of all, you have to use the saline implant because you can't shove this all the way up from the belly button to the breast. But second of all, you are taking an incision down here and doing a remote dissection, and getting the pocket correct is it's difficult, and I've seen more problems with it than I care to mention, and I don't do that procedure. I don't think it's a good idea. I've seen nice results in other people, but it's not for me. The other 3 incisions that are out there and viable: one underneath the armpit, one around the nipple, and one just underneath the breast here. In all cases with gel implants, the incisions are about 4 centimeters long. They're not long, and they tend to disappear. My favorite is the one underneath the breast. The reason for that is it decreases capsular contracture. It is a much easier direct visualization of the pocket, so you could get it just right, and that is the key to the surgery, is getting the pocket right. Around the nipple, your nipple has to be big enough to do that, so not everybody's a candidate for it. And under the arm, I feel like there's too much bacteria under there, and the risk of capsular contracture in both the nipple and under the arm incision the capsular contracture risk is higher in both of those cases. So for me, everybody gets an incision just under the breast, and I can't even remember somebody complaining about their incision. It becomes invisible, first of all, and it's hidden by the ptosis of your breast. So when your breast kind of flops down, you can't even see that incision. Okay, so the first question is whether you're going to get a silicone or a saline implant. There's a lot of controversy back in the 90s about silicone implants when they were actually taken off the market because there were people who felt that they may be making them ill. They were the most extensively studied medical device that's been through FDA clearance and have been found to date to be completely safe. To the point where I have them myself. I would feel very comfortable putting them into my family, and we're talking about silicone gel implants. But still, the choice remains. There still exist saline implants on the market that you could get if you don't feel comfortable having the silicone in your body. There's also a newer form of a saline implant, which I'll show you, which is a little bit more natural feeling than traditional saline implants. So starting with the difference between silicone and saline implants, I would say from the standpoint of the implant feeling like your natural breast, a silicone implant is heads and shoulders above saline implants. They feel much more natural, and unfortunately you can't feel them through the internet, but I can tell you it feels very similar to your normal breast tissue, to the point where I would say the comparison between saline and silicone implants would be a comparison between a Polaroid picture and a digital camera photo. These are far more advanced devices. So you may ask why people would decide on doing a saline implant ever. And to me, there's really one good reason for it, but I can tell you my bias is usually to recommend the gel implants because they are far superior. Why I say they're superior is because, number one, they're optimally filled in the factory. So when we get this in the operating room, it comes just like this and we put it in. And by optimally filled, what we mean is that the balance between how it feels and how soft it is to approximate how your breast feels is balanced to the negative of overfilling it would mean it would feel too firm. But if we underfill it, you see the wrinkles that are in the side, you may be able to see those through your skin. So through the years and generations of silicone implants, they've come with this optimal fill that balances those situations. When you look at these implants, you can see that this implant in my left hand is an earlier generation implant. It's very soft and feels great, but there's a lot of rippling and wrinkling. This is a more recent generation of implants where it's still nice and soft and approximates the feel of real breast tissue, but you don't see those wrinkles. So those are the advances that they've made. In the operating room with a saline implant, we get an empty implant and we actually fill it by hand through a closed system. It's sterile, but there's no optimization and absolutely no control over how much people are putting in each of those implants. So that's a drawback of the saline implants. The saline implants are also just like a bag of fluid, and they feel like that. The newer saline implant is the ideal implant, which I have here. It doesn't feel nearly as good as this gel implant. But the difference between this and a bag of fluid that's the saline implant is there's layers of silicone in between, layered interspersed in this implant, so it makes it feel a little more gentle, a little more natural. So the question then remains, why would anybody use a saline implant over a gel implant? The truth is that the shell of both implants is made of silicone. So no matter what you get, silicone is in contact with your body. The difference is what it's filled with. And the truth of any implant, gel or silicone is gel, so gel or saline, is that there is a 1% risk of rupture every year after you put it in. So at 10 years, you're at a 10% risk of rupture. At 15 years, you're at a 15% risk of rupture. So if you have a saline implant in there and it ruptures, you know it instantly because your breast will just flatten out to nothing and it'll be quite obvious that it happened. In a gel implant, if a rupture happens, it's just contained within the capsule of that breast. And I'll explain to you what a capsule is. But it's contained in there, and sometimes you don't even know it's happened until you either get an ultrasound or mammogram for cancer screening, or you may notice that there's a little bit of a change, but it's not always so clear. And when we go back in and operate on people who've had an implant rupture, it tends to be a little bit more difficult to get everything out. It's not going to spread around your body and make you sick. It just is more of a nuisance in the operating room and can lead to capsular contracture and things that I'll explain to you in just a minute. So what I tell people who have gel implants is that if they get a gel implant, it's not a lifetime device, and I would recommend swapping it out for a new device at about that 10 to 15 year period, maybe 20, depending on where you're comfortable. Because at 20 years, you're at a 20% risk of having that rupture. It's good to just swap it out to a new device. With a saline implant, you could leave the device in until you know it's ruptured because it's really not going to harm you in any other way. So that is the one positive of the saline implants that I could put forward to people is that if you want to do this one and done and not think about it again unless you have a problem, saline could be the way to go, but you'd be trading a lot of that natural feel and quality of that implant for that luxury. So that's where it is. I could tell you that 95% of ladies in my practice who get implants get silicone gel implants, and that's what I have in myself. So there's a lot of different kinds of, we're going to just talk about gel implants now. There are a lot of different types, shapes, sizes, textures of implants, and I'm going to explain to you why I pretty much always use a silicone round gel implant. You have, this is smooth, round gel. This is a shaped implant. A lot of times people would consider that a gummy bear implant. I never use these for several reasons. I'll explain it. And here's just a textured implant. If you felt this, it's just got like, it feels like, I don't know, it's not smooth. So why don't I use these implants? I don't use them because of the texture on the surface. If you paid attention at all to augmentation surgery or breast implants, you may have heard of ALCL, which is a lymphoma that is associated with breast implants and is almost exclusively found in that patient population. And it's an exceedingly rare condition that happens with breast implants, but the vast majority, and I would say 99% of cases, there may have been one or two cases with smooth implants, but all those people had some sort of texture in them prior to the smooth implant. But the vast majority happen when ladies have had textured implants placed. The cure for it is to remove the implant and remove the capsule, and in the vast majority of those already small group of people, that's a cure for it. There are a handful of people who have gone on to require systemic treatment with chemotherapy, and there have been a couple of deaths associated, but all in all, the cases of it are in the range of about 400 or 500 cases to 30 million people who have breast implants. So even in this patient population, it's a very rare thing that happens, but even with that, I don't want anybody to have to worry about it. I wouldn't put it in myself, and so I won't put it in you. When you put an implant into your body is gonna recognize it as not you, as a foreign material. So its reaction to that is it's gonna protect you from it. And so what it does is it forms a scar around it, and that we call that scar a capsule. That's just a bit of fibrous scar tissue around the implant that it's gossamer thin, and the vast majority of people, they don't even know it's there. You can't feel it. When you reoperate on these people, it's thin and you don't see it at all. But it happens in everybody. So that's the capsule. Capsular contracture is a pathologic condition in which that capsule or that very, very thin scar tissue around the implant for some reason gets thickened. And that could be any level of thickening from just a little bit thicker than that thin gossamer film to really thick and hard and calcified and painful. So there are grades of capsular contracture that can happen. We tend to think that capsular contracture happens because of some sort of subclinical bacterial contamination of the pocket, either at the time of surgery or sometime after. So we want to do everything we can to prevent capsular contracture. In the operating room, some of the things that we do are we give you IV antibiotics through your IV at the time of induction of anesthesia. And I always send people home with a prescription for antibiotics after, because if it is a bacterial contamination, that's going to cut down on the risk of that. Making sure in the operating room that nobody but I touch the implant. That's a no-touch technique. I use a Keller funnel, which makes sure that even the implant doesn't touch your skin as it's going in through the incision. And minimizing bleeding, making sure the pocket is clean. But there are a couple other things that we can do to minimize the risk of capsular contracture. We use Singular, which is an allergy medication. We use it at night for about a month or two after surgery so that it decreases inflammation. So we're always paying attention to this. I used to put textured implants in because there is a lower risk of capsular contracture with textured implants, but on balance, I don't think that any risk of having a lymphoma is worth the risk of negating capsular contracture. The next subject is where we put the implant, whether we go over or under the muscle. And there is vast amounts of opinions about this. And if you ask 100 plastic surgeons, 50% of them will say one thing and the other 50% will say the other thing. What I could say is it really does depend upon the patient. There are certain patients who are absolutely not great candidates for going over the muscle because they don't have any breast tissue at all to hide the edge of the implant. And then some people who really need to be above the muscle because their breasts have a little bit of ptosis or sag to them, so that they need that implant above the muscle to fill in that loose tissue envelope. So when I see a patient, I take their particular case on a case-to-case basis and I decide what is the best position for them. So this is not a cookie cutter approach. It's not a one size fits all. And anybody who has a dogmatic opinion about where something needs to be is really wrong. They should be able to do things both ways and tailor it to your particular situation. Having said that, I do have a bias for the vast majority of people who just land right in the middle. My preferred position is to put the implant above the muscle. The reasons why, there's pros and cons to both positions. Under the muscle has the added benefit of leaving an extra layer of tissue to cover the edge of that implant. So it's really a dual plane. So when you put the implant in, you lift the pec muscle and reflect it up above the muscle. So your implant is covered in the upper half or upper 3/4 down to the level of your nipple, but then the lower portion of the implant's actually covered by breast. So it's in two planes. And that leaves an extra, your muscle being here underneath the skin layer, it leaves an extra layer of tissue to hide the edge of that implant and disguise any kind of rippling or wrinkling. So that's a nice reason to put it under the muscle in people who have no breast tissue at all. And if you lifted their breasts and put that implant above the muscle, it'd be a thin layer to cover this. So that's one group that I almost always put it in at that dual plane position. Another good reason to put it underneath the muscle is because the risk of capsular contracture, which I just told you about, is actually higher if you go above the muscle. And we're talking a couple of percentage points. So if the capsular contracture risk across the entire population is about 4%, the risk of it going above the muscle is probably in the range of 6 to 8%. So it's a little bit higher risk of capsular contracture above the muscle. So you might ask me, why do I prefer it going over the muscle? And I used to never give my opinion about this until I had implants in myself. And I did my first operation, I had the implants put under the muscle. And I had what's called animation. When you put the implant under the muscle, your pec muscle still functions. So when you flex or reach up into a cabinet or open a drawer and you activate that pec muscle, you could feel your implant going like this, and it aggravated me to no end. So when I went back for my second operation, my wonderful plastic surgeon who did my surgery put my muscle back down and put my implants above the muscle, and I've been great ever since. And it was such a relief for me. So to me, and I don't have any capsular contracture, so it's easy for me to say that I really prefer it, but you really do need to think about animation, because I think that it's a lot more common than people give it credit for, and that's just where I am. If you get a problem with it, just remember, we could always flip the pocket. We could go back in and change it. So sizing. Getting a pair of breast implants is very similar to getting a pair of pants or a shirt or something. You don't want to get something that does not fit your body because it won't look right. So we don't want to squeeze something huge into you, or by the same token, we don't want to get something too small that doesn't adequately fit the pocket or your chest wall and that. We also want to think about what your goals are. Some people come in to me and they really want to look like they have breast implants, although it's less common in Connecticut. Some areas it's more desirable look to have upper pole fill and to really look like there's been something done. I could say the vast majority of the people who come in to me do not want that. The first thing they say is they don't want anybody to know they did this. So those are the kind of things we're thinking about. So we need to make sure, A, that the implant fits to your chest wall, and we'll do that with measurements. And basically, we're looking at the base diameter of the implant. That means the measurement from here to here needs to fit in your chest wall from here to here. So we'll measure the distance from here to here, and it's got to pretty much match up this distance from side to side. So within that range of base diameter, there are going to be a couple of different sizes that'll work for your body. And if you want something that's a little bit bigger, and we're keeping the measurement limited to the width of your chest wall, we might use the profile implant of the implant to get more volume in. So these are two different implants with different profiles. This is a high profile implant, and this is a low profile implant. They're the same volume, but you could see the volume of this one is distributed in the width, whereas the volume of this implant is distributed in the height. So if somebody's base diameter fits into this range and they want more volume, we could distribute it and put a higher profile implant. When you do put a higher profile implant in, you're going to get more upper pole fill, which means they're going to look more artificial. So in somebody who tells me they want to look more natural, I'm looking for some of the more lower profile implants. If somebody's major goal is to get it so their breast has a lot of fill up here to the top of their breast, then I'm going to pick a higher profile implant. So when you're coming in for your sizing, I ask people to wear a sports bra without any padding in it. And I have these sizers that they put in their sports bra and put their shirt on and look to see a general size of what they're going to like. I can tell you the vast majority of people are somewhere in the 300 to 400 range in my practice. 350 I think is the national average of a moderate plus profile implant, but there's hundreds of different sizes and profiles. So trying out the size is really catered to you, and in my practice is to decide what size that implant is going to be before you even go to sleep in the operating room. You're going to know what size you're getting. Some people do it differently, but I like you to participate in that decision. Okay, so I want to show you some examples of my results. I think really the most important decision you're going to make is which surgeon does your surgery, and to do that, you have to feel comfortable with them and trust them, but mostly you need to know that their aesthetic matches yours. So ask for their before and after pictures. They should be willing to show them to you. I have hundreds of them, which means I've done a lot. But that's something that's important. The choice of surgeon sometimes is very difficult. I could see why it would be tough, but those are some of the clues that can help you. And make sure they are boarded by the American Board of Plastic Surgery. And one last thing is sometimes people need more than just an implant. If your nipples are sagging and in the wrong place, sometimes we need to do a lift of the breast at the same time that we're putting the implant in. So your nipple is supposed to sit right in the center of your breast, basically your inframammary crease, or the crease underneath your breast. Your nipple is supposed to sit at least at it, maybe slightly above. If it's descended down to the lower portion of your breast or is pointed in the southward direction, sometimes you're somebody who's going to need to have a lift at the same time as the augmentation procedure, and I'll show you some pictures of that. But that entails an incision around the nipple and straight down, and maybe a little limited incision underneath the breast, so the scars are a little bit more extensive, but the goal would be to get the nipple to be placed at the center of the implant. Because if you don't do a lift and you need it, you're going to have the implant sitting in the footprint of where your breast should be, but your nipple will look like it's falling off of the implant, and it's not very attractive. So sometimes we have to do that, and I'll show you some pictures.
The single most important decision that you are going to make with regards to the surgery is who you choose to do your surgery. To help make that decision, first make sure your surgeon is board certified by the American Board of Plastic and Reconstructive Surgery. This symbol indicates that a surgeon has board certification. That's a baseline. Once you've confirmed that your surgeon is board certified, then you'll want to know what their experience and training is. Dr. Collins is double board certified in general surgery and plastic and reconstructive surgery. Additionally, she did a specialty fellowship in breast and body contouring, and as such, she is uniquely qualified in body contouring procedures such as breast augmentation surgery. Finally, and most important of all, you need to share an aesthetic with the doctor that you choose. He or she must have the same or similar idea of what constitutes the beautiful normal. In order to find this out, ask to see pictures. Before and after pictures will give you an idea of what the doctor thinks is a good result and should give you an idea of what is a reasonable expectation. The more pictures they have to show you, the better. Try to find pictures of patients who are close to your body type to get an idea of what your before and after result may look like. Here are some examples of my breast augmentation results. Note that all patients have kindly given their permission to show their pictures, and all identifying markings have been removed to protect their identity. In this case, because there was little to no native breast tissue to cover the edge of the implant, a submuscular placement was used. This gives an added layer of tissue to give a softer and more natural appearance and to minimize the risk of visible rippling. In this case, a subglandular or above the muscle position was selected because this patient had enough breast tissue to cover the upper pole of the implant. But in addition to that, her breast tissue envelope was loose and needed to be filled with the device. Going above the muscle in this case allowed the implant to fill the loose tissue and avoided the problem that a submuscular implant would create of the nipple appearing to fall off or cascade off of the implant.